Good afternoon. My name is Sarah Holcomb, and I will be presenting the proposed program evaluation of Missouri's long-term care ombudsman program. Here is the outline of my presentation. As an introduction, just want to tell you a little bit about long-term care in Missouri. Long-term care facilities provide essential housing, healthcare, and daily support for millions of older adults with individual and chronic health conditions. And for many residents, these facilities become their primary home. However, due to age, illness, cognitive decline, or limited family involvement, many residents are unable to advocate for themselves. This makes them very vulnerable to neglect, abuse, and violations of their rights. The COVID-19 pandemic further exposed serious gaps in long-term care systems, particularly related to quality of care, oversight, and resident safety. These concerns highlight the importance of strong advocacy programs such as the Long-Term Care Ombudsman Program. Missouri faces significant challenges in the quality of long-term care services. According to the national rankings, the state consistently performs below average, currently ranking near the bottom for long-term care quality. These low rankings are largely driven by systemic issues such as staffing shortages, limited accountability, and insufficient oversight of nursing facilities. When facilities are understaffed or poorly monitored, residents are more likely to experience unmet care needs and reduced quality of life. And as more baby boomers require long-term care services, the demand on an already strained system will increase, making effective advocacy and oversight more critical than ever. This proposed evaluation will take place in Missouri's more than 1,100 licensed nursing homes and care facilities. The evaluation will be conducted by the Missouri Coalition for Quality Care, an independent nonprofit organization dedicated to ensuring safe, dignified, and high-quality long-term care for Missourians. The program that will be evaluated, of course, is the Missouri Long-Term Care Ombudsman Program. Several environmental factors will make this evaluation especially important, including persistent staffing shortage, inconsistent quality of care, and ongoing post-COVID challenges related to safety and oversight. These conditions increase residents' vulnerability and highlight the critical role of the Ombudsman Program in protecting residents' rights and overall well-being. The Ombudsman Program is federally mandated under the Older Americans Act. The Missouri program operates statewide through 10 regional offices aligned with the Missouri's area agencies on aging and is supported by both trained staff, paid staff, and volunteers. Ombudsmen focus on investigating and resolving resident complaints, educating residents and family, and promoting residents' legal rights and providing community education. All activities and outcomes will be documented through the NORS system, which is the National Ombudsman Reporting System, to support accountability and evaluation. So why do we need this program evaluation? The Ombudsman Program is really the only large-scale path for advocacy for anyone who's living in a Missouri nursing home. Our program evaluation will focus on 5 research questions, though, that are on this slide. So, as listed, do residents' quality of life improve when complaints are handled effectively? Are residents concerned about addressed fairly by the ombudsman? Are residents adequately protected from retaliation? And then there's 2 more listed there. First, we need to know who can participate, though. So in this proposed study, we will include 1,200 nursing home residents from all the licensed facilities in Missouri and adding 100 more than necessary to account for potential attrition due to circumstances such as illness or death. These are individuals who have specifically requested ombudsman services already, though. To be included, residents must be cognitively able to give consent, maintain their own guardianship, and be Medicare or Medicaid eligible. We will exclude residents at the end of life, those unable to consent, and private pay residents because they will not do Medicare and Medicaid. Clients have to have assessments every 3 months, and private pay residents do not. The ombudsman will be included if they agree to collaborate with the Missouri Coalition for Care. And then finally, the study follows the Belmont Report principles. for human subjects, which is respect for persons, beneficence, and justice. These are the materials that will be used in this evaluation. The first tool is the minimum data set, or the MDS 3.0. This is a federally required assessment completed in every Medicare or Medicaid certified nursing facility. Importantly, the MDS has strong reliability and validity with consistent inter-rater agreement across facilities and well-validated clinical indicators. The PHQ-9 is included with the MDS, which is also an assessment for depression. Next, we will use the quality of life scale. The QALS has demonstrated high reliability with strong internal consistency and strong construct validity. It correlates highly with other established quality of life tools. For example, correlations with the life satisfaction index range from 0.67 to 0.75, demonstrating convergent validity. We will also use the Ombudsman reporting system, and it's standardized through all 50 states. Finally, residents will complete a 5-question follow-up survey 1 month after their case is closed. For this evaluation, we will use a mixed methods quasi-experiment design, which allows us to collect both quantitative and qualitative data without randomly assigning participants. Our procedures follow a 3-point data collection process. Before the intervention, most residents have already completed a minimum data set, which is required every 3 months. So we will use that information. And when a resident requests an ombudsman, the ombudsman will then notify the Missouri Coalition for Care, Quality Care, and then MCQC staff will then explain the study to the resident, obtain consent, and administer the first baseline quality of life scale. During the intervention period where the ombudsman is starting to address those residents' concerns, MCQC will complete the mid-intervention quality of life scale by phone. Sometimes they will ask the nursing staff to help in that process. For the post-intervention phase, data collection will occur 1 month after the ombudsman closes the case. This 1 month waiting period allows residents enough time to experience the results of the intervention that the ombudsman has created. Overall, this structural process ensures that we track changes in quality of life while also capturing detailed information about what the ombudsman does and how the residents perceive the support they received. For the data analysis portion of this evaluation, we will combine quantitative and qualitative methods. First, we will analyze the minimum data set information obtained from CMS. This includes demographic and clinical variables such as residents' gender, depression scores using the PHQ-9, and their functional status based on the activities of daily living. Next, for the quantitative outcome analysis, we will use SPSS, which is a statistical computer program to examine changes over time in both quality of life and PHQ-9 depression scores. Now, because residents will be assessed at 3 different time points, we will use a repeated measures ANOVA. This statistical test allows us to determine whether there are significant improvements in residents' well-being across the 3 stages of the ombudsman intervention. We will also conduct a descriptive analysis of the NORS data. Finally, for the qualitative analysis, the responses to the 5 open-ended survey questions will be entered into the Max QDA, which will code the residents' responses to identify reoccurring themes and patterns related to the residents' experiences with the Ombudsman program. This thematic analysis will provide valuable insight into what residents found helpful and where the program might be improved. Together, these quantitative and qualitative measures give us a comprehensive understanding of both the measurable changes in resident outcomes and their personal perceptions of the Ombudsman service. This logic model illustrates how the long-term care ombudsman program uses its resources to achieve both short and long-term outcomes for residents in long-term care facilities in Missouri. The model begins with program inputs, then highlights activities and participants, then highlights outcomes. Ultimately, the research model anticipates long-term impacts such as reduced abuse and neglect, remediation of complaints, improved quality of life for residents, and broader policy advocacy. On this slide, you will see the proposed budget for this program evaluation. And on the next slide, I will go through the expenses section by section. So the first section of the budget is staffing, and I'm just going to go through each of these. We will have first the program director of Missouri Quality MCQC. Her role includes participating in team meetings, aiding in the recruitment and training of site supervisors, coordinating with Missouri Ombudsman and University, and then assisting with the data analysis and interpretation of the Ombudsman program. Then we have state supervisors. They will build relationships with nursing homes and the Ombudsman office, train Ombudsman, and then collaborate to gather data. The team also will visit the nursing homes for oversight and quality assurance. Other personnel are the data analysis, who will look at all the data and interpret that for data collection and analysis of all the data for MCQC. The administrative assistant will support all the other staff and then coordinate schedules, manage documentation, maintain files, etc. And then, of course, our hands on the ground feet are our graduate research assistants. They will support MCQC by assessing nursing home residents, collecting and recording data, and assisting with program documentation. This evaluation requires at least some other expenses. So per laptop, which we will need at least 6, will be $400. Then we need office supplies. Mileage is calculated at 66 cents per mile as per federal guidelines. It's estimated that we will travel 10,440 miles across all of Missouri with a net cost of $6,890. The Max QDA software is $3,668. The SPSS quantitative data analysis software is $1,524. And then in summary, our program evaluation of the Missouri Long-Term Care Ombudsman program, we really want to ensure that residents in the state of Missouri get the best advocacy and having their concerns addressed effectively. This program evaluation will hopefully create actionable steps for improvements that are data-driven, that are transparent, and protect our residents. Thank you for listening and hopefully supporting this program evaluation. And here are my references.